Live every day as if it were the last, because before you know it, time goes past and life's just not that long. Tell all you love that you love them so, because even if you do, they might not know. And one day...
Today my guests are Janice and Denise. And Janice, a longtime friend, and I posed naked for her bachelorette party downtown, Sunshine Building on Central and 2nd Street years ago. And
2008.
Okay, 16 years. All right. And Janice has visited in my home, and she and I have danced together. And Denise, whom I just met today, and we're going to have a good conversation.
Yes, we are. I'm looking forward to it.
Fine.
Thank you, Dawn.
And I want to ask, you know, what are the main opioid drugs people in Albuquerque use?
So what I'm experiencing with that is fentanyl.
Yeah.
And we all are aware when COVID came in, that's when we saw fentanyl really peak here in Albuquerque. What we're seeing here today, as of September the 17th, it was posted through the governor's office and New Mexico Department of Health. We are learning that the substances that we're finding are bare minimal traces of fentanyl. We are also learning of the chemicals, industrial pesticides.
In the fentanyl?
Correct.
That's correct. And then industrial, the plastic coating.
Oh my.
And so now what we're recognizing is that we're seeing another shift. So we're seeing our fentanyl users transition back to the heroin.
Oh, really?
Absolutely. Now, how long that is going to last, I don't know.
So the main two are fentanyl and heroin.
Right. And what we do know about fentanyl is that it's 50 times more powerful, and the withdrawals are like 100 times worse
Than heroin?
than heroin.
Correct.
Really?
And the lifespan of fentanyl is 13 minutes, which obviously you have to continue that use, right?
13 minutes?
Yeah, 13 minutes is the lifespan of fentanyl.
So that would be a substance that is considered to be with a very high addiction potential, because you consume it, you experience, all these feelings of euphoria and pain relief, but it's very short-lived.
Just 13 minutes?
13 minutes.
Just a very brief period of time, and so many people who do use it, they'll be consuming it repeatedly through the day.
What about at night when there's sleeping?
Sometimes at night, depending. And just to elaborate on what Denise said, some of the ways that we know what kind of substances are available in the community include reports from individuals who might say, golly, I'm sure glad that heroin's back on the scene, because people die very quickly from fentanyl.
Right.
It's easy to overdose because of what Denise mentioned, the increased potency per dose. However, you can compare that to people who sometimes have used heroin for decades.
Oh, yes.
And so, the fatality rate when it comes to heroin is lower than when it comes to the fentanyl. And then we also have organizations that are helping us to understand more accurately what substances are out there. And so, I'll shout out the New Mexico Harm Reduction Collaborative. They have a machine called an FTIR machine. I understand it's only one of 2 in the entire state that is used to test chemical composition.
Really?
And so someone can bring to them a pill, a powder, and they'll go ahead. First, they have preliminary testing, where they'll get an idea of what is in that substance, and then they actually ship it out to a laboratory, where they'll do more refined testing. And so they'll be able to tell you, you know, if someone walks in and says, hey, this blue pill that I have, this is fentanyl, they'll take it and they'll test it. And they might say, well, it's actually not fentanyl. It's filler material, which could be a variety of different, as Denise said, household, industrial chemicals, sometimes other over-the-counter drugs or prescription drugs that they'll mix all together into sort of a cocktail.
And they do that in order to make more money?
Correct.
I see.
Correct. In particular, we've also seen recently they've had this substance mixture for a long time in other places, like in Philadelphia, they've called it trank, and they've had that for several years, which is where they mix the fentanyl, which is very short-acting, with another drug. It's used for veterinary sedation, so typically for sheep, cows, and they mix that with the fentanyl because it's cheaper, and then it makes it last longer.
And that's xylazine.
That's xylazine, correct.
And
xylazine, it was not produced or approved by the Food and Drug Administration because it is known to cause blood pressure fluctuations in humans. And it also causes really bad skin lesions or sores. You know, that for you and I, if we have, say, you know, an open skin wound, and we can wash it and keep it clean and covered and all of these things, it's probably not going to present a severe complication. But for a person who's perhaps living outside and doesn't have access to a shower, to running water, to clean covers for their wound, it could eventually turn into an infection, which can cause, in Philadelphia, they've seen a lot of limb amputations, and they've had a lot of deaths from sepsis. And so, you know, we're trying to be aware of all the different kinds of substances that could be in our illicit supply, and to be strategic and have plans and treatment facilities for how to address this very complex, dynamic, and evolving issue.
Now, years ago, here in Albuquerque, I had friends on heroin. But what are some of the signs usually that somebody is using heroin or fentanyl? How do they act?
Well, first of all, I'd like to just state that it doesn't discriminate. It can happen to anyone. And obviously, for those of us living in Albuquerque and providing harm reduction to our individuals, unfortunately to our homeless population, you know, everybody wants to stigmatize that everybody that's homeless, they're homeless because they're doing drugs or they're crazy, they're mental illness. And for me, that's not the case. That's not my experience out here. And I'm not saying for all, but I'm saying, like, we really need to take a look at post-COVID, how that has really impacted our population out here too, because we are seeing the ripple effects. Our numbers have certainly increased, and I don't even believe we have a concrete number, and Janice can elaborate a little bit more on that. I only know what I'm servicing on Friday and Saturday nights. I'm out here from 10 p.m. to about 5 o'clock in the morning. And I am servicing, on average, a minimum of 300, a maximum of 500 people.
And I'm one shift?
From 10 p.m. to 5 a.m. And I am not talking about servicing the same individual twice.
Really?
These are all different individuals.
And you use Narcan?
Throughout our city, and absolutely, we provide Narcan, absolutely.
Have you lost any to death?
I have. I have. And I want to say, and I've been out here for a minute, since 2008, working in my in my backyard.
Denise is a hero.
Yeah.
That's right.
Yeah.
So, you know, unfortunately, those are the consequences, right?
Yeah.
Especially We just recently got those machines, just recently in the last, 3 years?
The FTIRs.
So the FTIR, right, which have really made an impact, but even with that, we're experiencing some barriers of having access to them. But our overdoses are coming down.
Good.
They
good.
definitely are coming down.
This is the first that they've come down in
Right.
more than 5 years.
Right.
They had been
Wonderful.
up,
Right.
and now they're starting to come down. But I would like to add to that
Absolutely.
that when we look by demographic, it's not coming down for everyone.
Right.
People of color, people who identify as LGBTQIA are still having,
Really?
on average, higher than the general population in terms of death by overdose. And so, this downtick that we have seen only in the last year in
Right.
deaths from overdose is not evenly distributed in the population.
Right.
There are still equity issues that we're trying to address, and perhaps this would be a good segue to give brief introductions of where each of us work to talk about
Please,
the equity
please.
aspect.
Yes.
Sure, go right ahead, Denise.
So my name's Denise Safchuk, and I'm a licensed substance abuse assessment counselor. And I'm also a certified peer support worker with the state of New Mexico and a harm reduction specialist with the state of New Mexico. And that entails me to, they're all very important, whatever. To me, I'm not really impressed with licensing or certifications.
Right.
But you have to have them.
Yeah.
You know, and with these certifications, I love under the umbrella where it allows me to go. You know, it allows me to provide street outreach and wraparound services and soft handoffs, and it allows me to network with other facilities in our community, building rapport, building partnerships. Janice, that's how we came to be.
Right, right.
And Janice and I have been working together, I want to say going on 4 years now?
About 3.
About 4,
Yeah.
oh, about 3 years?
About 3,
Okay.
Coming up on 4.
Yeah, so, I mean, time goes so fast, right?
Yeah.
But
Oh,
it's
yeah.
important.
How did you get involved?
So I'm a woman in long-term recovery, and I have been stigmatized. I have been called a straight-up junkie, and I have long-term recovery. And I really believe that when I got clean and sober, a lot of facilities weren't available. Matter of fact, there was bare minimum. We didn't talk about things.
Right.
There was no needle exchange program. There was no harm reduction. Matter of fact, insurances didn't even recognize it as a disease. If you wanted help, you paid out of pocket. And today it's very, very different, and I'm so grateful for that. And I want to be out here servicing our people, my people, because I wish there would have been someone like me out here.
Right.
And I do know what it is to be stigmatized against.
Yeah.
And it's not a good feeling.
Oh no, hell no.
Does an addict or an alcoholic make them a bad individual? Absolutely not.
Right.
The most intelligent, intuitive people I've ever met are addicts and alcoholics. I mean, super intuitive, very sensitive, and smart. Really smart individuals, gifted. But unfortunately, they suffer from the disease of addiction. And I do want to touch on this real quick, and then Janice, you
Go
can
right ahead.
elaborate. Because that stigma of the mental illness, right? Now, most people that may start out, maybe they start out with the mental illness already there, and they're self-medicating to treat that mental illness. And then there's those individuals that start maybe using for social or peer pressure, whatever that may look like. and then it turns into an addiction, which hence, left untreated, it will progress,
Sure.
which then we may develop a mental illness. And we know that left untreated, and that's for anything across the board, it's going to progress.
Sure. Now, if I am on the bus, I travel on the bus many, many times. How might I recognize someone who's on fentanyl? The way they act.
Well, I think fentanyl use is very evident.
Like what?
You will see nodding, the head going down, people hunched over sometimes, and that could also be a contributing factor to xylazine too. And you have to think about that, because of the potency of fentanyl. Are we correct on that? 50 times stronger than fentanyl? Or is it 50
It's
times?
50. Yep.
Okay. So you have to think.
If you compare two little jars and you say, what is a lethal dose of heroin and what is a lethal dose of fentanyl, the heroin will cover the bottom of the small vial. The fentanyl is just a couple of
2
grains
nanograms.
Oh,
2
my.
nanograms.
that would kill you.
2 nanograms
Very
is what
potent.
that is. So it is those symptoms, and for an individual as yourself, if you wanted to recognize, what's very prevalent today is fentanyl. You see individuals on our streets here in Albuquerque that are using it freely.
Oh, yeah.
And they're, and to me that is kind of, because that wasn't how it was, but unfortunately that's what we are observing. And it's not to say for the individual, it has to say about the fentanyl, because the fentanyl is not allowing them to do it in private because of the lifespan of it.
13 minutes.
Right.
A couple of other signs and symptoms that I could name could include pinpoint pupils. So, you know, their pupil in their eye gets very small. They may experience some loss of coordination. And so, you know, maybe they're kind of stumbling, leaning against a wall, not able to stand easily. You may also witness some deterioration of consciousness. So the person may appear to be, you know, kind of slumped or asleep. And one of the key factors when it comes to overdose is respiratory depression.
Right.
And so any kind of opioid, whether that be heroin, fentanyl, Oxycontin, Dilaudid, morphine, there's a number of them, you know, Percocet, Vicodins. If you have enough of them, it causes your central nervous system to slow down to where that person may not be breathing very well. And so if it starts to taper their breathing, you may also notice other signs and symptoms, like perhaps their lips start to turn blue and they're not responding well. Perhaps you notice that the color is gone out of their face. Perhaps they're making a snoring or a gurgling sound because their diaphragm, you know, everything's starting to kind of collapse because they're not respirating well. And then finally, you know, some of the final sort of things we may observe before, you know, they've died from overdose, they may stop breathing entirely. They may become unconscious totally and non-responsive. Even with, you know, I've personally been responding to people who appear unconscious on the side of the road since 2000. And, you know, it's recommended that if you can't get them to respond by, you know, shouting at them, maybe you nudge them in the foot, you know, and try to stir their body. And then finally, I'll come in and give them a good sternum rub with the fist right on their breastbone hard, which creates a pain response. And if they won't respond to that and they're not breathing, then I know I better call 911 right now. And I'd better start administering Narcan, which is a medication. It's a nasal spray. You put it in the person's nose to basically reverse the effects of the opioid temporarily so that they'll be able to start breathing again. And then while you're waiting for the medicine to work, you want to give that person what they call rescue breaths. So similar to CPR, except you're not doing the chest compressions. If their heart is still going, they don't need that. It's just giving them the oxygen until the paramedics come to help.
So how do you give the oxygen?
Great question. You want to do, first of all, you want to check if they have vomit or anything in their mouth, because an overdose can cause vomiting as well. Then you would give them what they call a finger sweep. And so you'd make sort of a hook with your finger. You come in along the cheek, you hook over the top of the mouth, around the side, and then pull it out if there's, something obstructing. And then you want to make sure the person's flat on their back, laying down. You're going to use one hand to tilt back their chin to open their throat. With the other hand, you pinch their nose. And then you make a seal over their mouth with your own. You give them a breath, and then you let go so that they can exhale that. And then you pinch them again, give them a second breath, and you want to watch.
Mouth to mouth.
Essentially, yes. Their chest should be rising, not the belly. And so you want to give them 2 breaths like that. And then you would administer the Narcan medication to their nasal passage. And then you're going to continue with 1 breath every 5 seconds until either the person will start to breathe on their own from the medication that you've given them, or the paramedics will come and they'll take over for you. And the great thing about Narcan is that it is non-toxic. And so if that person, let's say they had a stroke, it wasn't an overdose at all, and you gave them the Narcan, you're not going to hurt them.
I see.
It can even be given to babies.
Really?
And I've distributed to people who told me after the fact, they were living outside, and their dog, their support animal, had eaten pills and just fallen over, and they gave it to the dog, and it brought the dog back too.
Oh my.
Yeah, and so it's a life-saving tool. And I believe Narcan should be available all over the community. That lay people, people who are not medics, should also have it and be prepared to use it. Because, one of my mentors, Pelletier Trujillo, rest in power, taught me that what we're trying to do here is to keep people alive long enough for them to choose recovery for themselves. Because there's no recovery from death, as we know. And we've all lost loved ones here.
It's permanent.
We've all lost loved ones. So.
And we also want to talk about the lifespan of Narcan. So Narcan has a 90-minute lifespan. It doesn't absorb the opiates in the body. It attaches to the receptors on the brain, and it is a blocker. So, and that's what will bring the individual out of the overdose. And what's very important, and people need to learn and understand, is that when an individual comes out of an overdose, they are in acute withdrawal. And that's because of it being on the receptors of the brain. But after night, people want to use immediately afterwards. But the truth is, and the facts are, is that it's not going to do anything because the Narcan is still on the receptors of the brain. So we really encourage individuals to wait. And even with them waiting that 90 minutes, and it's sometimes can be excruciating, those withdrawals.
So even if they have the Narcan, they still have the withdrawal?
Right, and it's because of the Narcan.
They call
it's
that
attached.
Precipitated withdrawal.
Right.
You've taken a substance that blocks your body from absorbing the opioids that are in the bloodstream.
Right.
And so because all of a sudden that's cut off from your brain, it precipitates immediate withdrawal. And so there is a program they're working to initiate right now. I've heard it called, as a nickname, the golden ticket, where any person who they call paramedics for an opioid overdose would be offered on the spot induction therapy. So they'd be offering that person a prescription drug, Suboxone, that would help that person with their withdrawals, so they're not experiencing that extreme pain, discomfort, sickness that comes with withdrawals. And then they're going to try to transport them on the spot, if the person wants, into treatment. And
Right.
to me, that is a great window of
Oh, yeah.
opportunity. When someone has
Absolutely.
just come back from an overdose, they're more likely to accept that treatment. And so
Right.
having
yeah.
that as an option, I think,
Yeah.
is really great.
So have you, using Narcan, have you had people who are overdosing who say, no, I don't want it because I'm going to go into withdrawal?
Well, first of all, in an overdose, they don't respond.
They're unconscious.
If they are responding, that means they're just in a nod.
Yeah.
So we will not administer Narcan in that case. But I have had individuals where Narcan has been administered and they come out of the overdose and the first thing they want to do is use. And there's no sense in using. It's excruciating.
Right.
Another keynote to that is that because of the lifespan of Narcan, the 90 minutes, once that wears off, the opiates are still in the individual's body, okay? Because now the Narcan's not blocking it on the brain. So that puts that individual, because they're in acute withdrawals, at a higher risk for overdose. Again, for a second overdose.
Oh, really?
Yes, because the amount of opiates are still in the body. Are still in the body. 90 minutes is not a long time.
No.
So you either
so
need
you're-
to stay with that person
Right.
yourself or call 911,
Right.
have them transported.
Right.
Because if you just walk away, oh, now you're breathing, now you're fine, wait an hour and they might go right back out.
Right.
Yeah.
And I have seen that so many times. And it has to do because of the withdrawals are just excruciating.
Oh, my.
Yeah.
And then have you finished with your introduction and I'll go ahead and do mine?
Oh, yes.
Just doubling back?
I'm so sorry, everyone.
That's
I
okay.
do believe so. Did I talk about Project H2O?
No.
Okay, so just briefly, real
Sure.
quickly. I think it's been about 3 years. I noticed being out in our community and working with other facilities here in Albuquerque, Santa Fe, really throughout the state. Budget was a big thing. And we talk about overdose, we have to talk about different components. Are they getting good sleep, good nutrition?
Sure.
Are they staying hydrated? And are the facilities able to provide those kind of basic needs,
Sure,
right?
sure.
Food and water,
Yeah.
right?
I'll toss in the mix because it comes up in my work a lot.
Right.
Climate control. In the heat,
Oh,
there are more
yes.
deaths from
Yes.
overdose
Yeah.
or people dying of, extreme conditions.
Right.
Yeah.
So I
And
started.
cold, too?
Yeah.
Yeah.
Sure.
Yeah.
Yeah, exposure.
So I started Project H2O to provide. Project H2O is not a nonprofit. It is not a business. It is only a resource. And really, honestly, I've been able to provide to 26 facilities just in Albuquerque. And I'm talking pallets of water.
Really?
To bring relief to their budget to where they could utilize those monies elsewhere. And let me tell you, it has really been a privilege to be able to provide this resource.
Good.
And it's something that's continued on. Definitely it is needed out here with street outreach, certainly during our peak summer because of our temperatures.
Yeah.
And I also want to reiterate during our winter months as well.
Oh, yeah.
People tend to drink less water in the winter because it's
Right,
cold.
right.
So dehydration is really high in the winter as well. And which is another factor in the contributing factors of overdose, dehydration.
And your background, or your...
Yeah.
Yeah.
My name is Janice Herrera. I use she, her pronouns, and I work as a health promotion specialist at the Health Equity Council, which is a nonprofit organization working in public health for Bernalillo County, where we advocate for a better quality of life for all residents through equitable health care access, the programs and services that people need where they need them. And so in addition to my work, I'm currently a student at NMSU. I'm working on my master's certificate in public health. I'm also, thank you, a New Mexico harm reduction specialist. And then I've been pretty much a lifelong volunteer. And so the groups that I've worked with in the last year who have really supported me in providing resources for people, my neighbors who live outside, would include Project H2O, and who also, I'll add, regularly provide snacks, also regularly provide other sorts of beverages, you know, iced teas and things that in the summer people really love. And then also I work very closely with the Mutual Aid of Albuquerque, delivering care packages into encampments. I also get supplies regularly from the Whittier Food Hub, Catholic Charities, the International District Healthy Communities Coalition, A Light in the Night. So there's a number of different groups who, you know, we network with. We're all connected. And so, you know, I first started doing outreach into Coronado Park, which some people have also called Tent Park or the Train Park, you know, there at 2nd Street and I-40. I was at the time an AmeriCorps public ally, and I was working in food justice and sometimes had leftover things that I'd take there to the park and hand out, you know, probably about 10 years ago. And that's right there in the Wells Park neighborhood where I live. And so I started getting to know people and meeting neighbors, many of whom have been unhoused for a number of years, and then became sort of more acquainted with, you know, seeing people consume fentanyl and heroin. And I will also mention, which it's not come up yet in discussion, that a lot of folks are what they call polysubstance users, which means they're not only using opioids. Very commonly, perhaps they also drink alcohol, perhaps they're mixing it with methamphetamines, with benzodiazepines, you know, which could include Xanax is very common, Valium or other prescription drugs like that. And so, you know, if you look at in New Mexico the rate of overdoses, the largest percentage of them coming out of the Office of the Medical Investigator are what they call polysubstance. And so the person is mixing different things, which is another one of these extenuating factors that Denise talked about that then puts that individual at a higher risk. And so through my work at the Health Equity Council, we do some direct service. It's not our primary mission, but we do go out and do used syringe pickups. While we're doing that, we hand out Narcan. We go to different you know, governmental agencies, nonprofits, businesses, and we conduct Narcan training and give it to people for free. So I myself have distributed more than 1,500 kits of Narcan into the community. And then through our work, we also do policy work. And so we're analyzing what are the laws in New Mexico, what are the ordinances, what are the new things politicians are pushing forward, programs, initiatives, and how can we make them better and more accessible for everyone. And then we also do some educational work, especially along the lines of prevention. So trying to make it so that people don't start with a new habit. And then looking at harm reduction, which is once someone is already consuming substances, what tools can we give that person? Not only the Narcan, but, you know, unused syringes, syringe containers to safely dispose of them, alcohol wipes to clean the site so they don't get an abscess, and other such things to reduce the probability that that person will need intensive medical care down the line. And so in that vein of sort of, you know, education, there's a program that we do at my work called boot camp translation.
Okay.
And so the idea is we come up with different advertising, public service announcements. Sometimes they're print, so it might go on a billboard or on the side of a bus. Sometimes they're video or radio spots. And so for today, we have actually brought a couple of these videos to
Okay.
share. These ones in particular were developed by a group of high school seniors from different schools around Albuquerque. You know, so it's 18-year-olds deciding what do we think other 18-year-olds should hear that would help our group to be able to perhaps navigate around some of these serious issues. And in addition, we've had other cohorts where we had different groups. So we've done videos that were targeted to Spanish speakers, to high school counselors, LGBTQIA community members, and other groups, so that it's targeted advertising by people for people.
Right.
And I think that's what we're going to go ahead and segue into now is our first video.
Good, good.
It is a right.
Okay, excellent.
Okay. And so that was the first video, right?
Right.
And so there's a second one coming.
Yes, and just real quick before that second video plays, I think it is important that we educate our audience and reiterate the New Mexico Harm Reduction Act.
Okay.
That act was put into place not as a privilege, but as a right. And that means that it is their right to receive harm reduction. And that applies to all of us, all of us. I mean, so I just want to make that very pertinent because we have an audience, maybe, that thinks harm reduction specialists are enabling by providing. And for me, that is not the case at all.
Okay.
That is their right to have brand new product, whatever that may look like for that individual, one-time use, to provide harm reduction.
Are there enough treatment facilities, centers in New Mexico for the people who want to get off?
That's an excellent question. Me personally, absolutely not. We have a greater demand than we do supply. I do believe that we are working on it. Certainly, we're going to talk about the opiate settlement money and where those monies are going to address those issues.
My experience around trying to access treatment centers is that oftentimes individuals who are in what we call the golden hour, or in other words, they say, yes, right now I'm ready. When you start trying to get on the phone and actually find them a bed in a treatment center, it can be quite challenging. You know, there may be complications around whether this individual has insurance or not. There may be complications around, you know, different facilities will have wait lists. And the reason they call it the golden hour is because if you can't get that person through the door a week later, odds are they're already experiencing the withdrawal symptoms. They may go out and have a relapse, and then they change their mind, perhaps.
Or die.
Correct, yes.
Or die.
Yeah, unfortunately.
Because let's be very realistic about that. Because they are at greater risk for death. My experience as well in seeking treatment for individuals in the golden hour, I call it a moment of clarity, that if we can get them into somewhere and they can do their detox program, 7 to 10 day detox, then they're kind of transition back out because there's not a bed available for the 30, 60, 90
Right. Yeah,
inpatient. Again, what does that go back to? For me, it's set up for failure. And it's very simple. It's not rocket science, right?
Right.
If you send somebody back out after they've detoxed for 7 to 10 days,
Yeah.
and you put them right back into the environment that they came in out
Yeah.
of, what's going to happen?
True, and I suppose some of them have no close friends who don't use.
Absolutely. You better believe it. And not just that, but just the elements in the environment
Well, sure.
of being out here.
Yeah.
Being on high alert and the stress and
Oh,
duress.
yes, yes, yeah.
You know, or maybe to stay warm. I know people that they utilize substances just to stay warm.
Really?
Yes.
Absolutely.
A lot of people I know will sleep in the winter time during the day.
Right.
And so they're going to bed perhaps at 2 p.m., sleep
Yeah.
till 10 p.m. because it's the warmest part of the day.
Right,
You can
right.
be comfortable and
True,
sleep.
true.
Right.
And then 10 p.m. they're waking up, trying to stay alert all through the night so that
Yep.
they don't die of exposure, trying
Right.
to keep a fire going,
Right.
trying to keep the wetness out of their cardboard box or their tent or their tarp that they've tied up somewhere.
Right.
And so, you know, definitely people sometimes are relying on their substance to keep them alert and awake through the night so that they're not succumbing to the elements.
Do the substances actually keep their bodies any warmer or no?
I don't think
I don't
so.
think
I
so.
think it's been, and I don't know, don't quote me on this, okay? I don't know what statistics are. But we do experience higher numbers of hypothermia. And I believe a couple incidents have made the news where people have died from hypothermia and not even realizing that they're going into hypothermia.
Really?
So I don't think it really
Overheating,
does.
in other words.
Right,
Yeah,
right,
yeah, yeah.
right. So,
So the second video, are you ready for that?
Yes,
Okay.
absolutely. Okay, here we go. Where are we at?
you take the lead on it.
Okay.
I think we should.
Yeah.
I think that's an important topic.
I think we're back online. Okay.
Are we?
Okay.
Yeah,
All
okay.
right.
I'll very briefly touch on
Yeah.
just a couple of other aspects of the
Yes,
treatment
please.
centers, which would include that oftentimes the first bed that will open up is not in Albuquerque.
Oh,
And so I have personally taken people in my car who I've known for some time to drive them to other places so that they could get into a bed because they may not have otherwise had access. And then, you know, through the work that I've done, interviewing people, and this includes, you know, surveys, focus groups, attending town halls in regards to the opioid settlement funds, which I think we'll talk about in a moment. I've asked people, what would you want for treatment? And some of the things that have emerged from that where I perceive there are shortages is that some people have been through rehab many times
Yeah.
and it hasn't served them terribly well, and they express a desire for a longer treatment program. So the majority of them are going to be 25 to 30 days, and some people will say, I think I'd do better with 60. I think I'd do better with 90.
Sure.
And my best friend passed away on a wait list for a 90-day treatment center.
my.
And my best friend expressed to me, I feel like a failure because I've gone to rehab several times.
Right,
And I said,
right.
remember, the average person takes 7 trips through rehab
Really?
to obtain 2 years of abstinence.
Yeah.
And
that
so
does.
it's a process. It's not that you do it and you finish and
No,
you graduate
no,
and you're
no,
done.
no.
It's a
Right.
journey and a process. Other
Right.
things that people have expressed around treatment centers would be non-denominational treatment. So people don't want to be preached at
That's right,
sometimes when they're
that's
going
right.
for services.
Sure.
People have expressed a desire for gender-specific treatment. So women may not want to be in a sensitive, vulnerable place with men. You know, people have asked for more family-based counseling services and other things. And so really having this sort of right treatment at the right time is really what we're sort of lacking. And so doubling back over to the opioid settlement funds. Have you heard about these funds yourself?
Not much.
Not much. Okay. Well, we'll start with some really basic background information, and feel free to jump in. But basically, there was a class action lawsuit filed by multiple attorney generals from different states to sue Purdue Pharmacy, who gave us OxyContin, to sue CVS and Walgreens pharmacies, who pumped our community members full of prescription opioid drugs. And we know now that New Mexico received the highest concentration of opioid prescriptions per capita out of any state in the United States except for one. So they flooded our state with these highly addictive drugs, and they lied that they weren't addictive when they knew better. And then you had Johnson & Johnson, who had massive opioid fields in Asia and was importing these ingredients in mass. And they lost the lawsuit. These corporations lost, similar to the tobacco lawsuit. And so each state, county, city, governmental agency that was involved have received settlement funds to help provide support services, treatment, prevention, harm reduction to those communities that have been most impacted. And so New Mexico will be seeing collectively tens of millions of dollars coming in stages over the next 10 years. It starts off with bigger amounts and kind of dwindles down to help us to establish a better network of wraparound services and care for our community members who need it.
Do you think doctors are less likely now to prescribe this crap?
Yes. What I've heard, and you can elaborate as well, but what I've heard from community members is, well, golly, I went to the emergency room because I was having a kidney stone, and they wouldn't even give me any pain relievers. Or I've heard from people who, you know, maybe they have an abscess, and they've gone to the emergency room, and now because they don't have access to this substance that their body's used to, they're waiting hours there in the ER, they start going through withdrawals, and they'll go ask the front desk, well, can you give me something even just, you know, mild to help me? I'm getting sick. And they'll tell them, no, you're drug seeking. Go away if that's what you're here for. And so there have been, in my opinion, sort of this reversal or backlash, if you'll call it, around where once they were giving them out very liberally, now that doctors have, there's tracking programs where they're monitoring how much is each doctor giving out, who's getting what quantity for how long.
And I want to add to this because it is all being regulated now through the Drug Enforcement Agency. It is absolutely being tracked now. What we need to also talk about too is our elderly that have maybe, or veterans that have been on these pain meds, OxyContin specifically. Because let's face it, there are individuals with real pain that are suffering. Some individuals, they got prescribed because of a surgery, a back injury, whatever that may look like, right? I have worked with individuals 60 plus, and I'm talking up into in their 70s. Now all of a sudden they've been cut off these meds. So what's happening now? We talked about withdrawals. Okay, withdrawals from OxyContin are very severe. Could you imagine being 70, 75 years old and having withdrawals, right? So we are seeing our elderly going to our streets, seeking, okay? And again, anybody that does any opiate, we ask, who's at risk for an overdose? Anybody that is doing opiates. And I don't care what, it doesn't discriminate what the age is. If you're doing opiates, you're at risk. So we talked earlier about how are we able to identify somebody that's utilizing fentanyl. I have worked with individuals that are elderly, have bought product off the street, unable to test that product, and there was fentanyl in that product. They were being sold what they thought were Oxycontin.
It's a counterfeit pill.
Right.
So it looks like an Oxycontin, but it
Right.
doesn't contain that at all. It's got fentanyl instead.
But the harm reduction, the New Mexico Department of Health, we do have access to test strips. We can test for fentanyl, we can test for
Really?
xylazine. It's just about, you know, educating our community, and most of our individuals that are out here, they know where they can find these products. Part of our street outreach, Janice is very prevalent out here in our community with her street outreach and providing these products because they can save a life.
Yeah, yeah.
Now, whether or not once they test that product, whether or not they make a choice to do it or not do it, you know, but at least they're being provided the product to empower them, you know.
Yeah.
And then doubling back to the opioid settlement funds very quickly, some of the other things that people in the community who are impacted have asked our local government to spend these funds on include, in addition to more treatment centers, as we talked about already, people have asked for a 24-hour drop-in center where they could go any time of day to get Narcan, wound care, harm reduction supplies, and they should have a staff member who could help guide them into a treatment bed if that's what they would like. People have also asked for a safe consumption site. So a place that someone could go, they would sit in a room by themselves to consume whatever it is that they regularly use, and there would be medical staff on hand. So if there was an overdose, they would come right in. They've had these for years in Canada and have not had one death on site. That's right.
Amazing.
Amazing, yeah. And so I see the opioid settlement funds as an opportunity for our community to invest in itself and to have better outcomes for those who have been really impacted. And I've been asking our local government to please give us transparency and accountability in these tens of millions of dollars. I want them to report on how much money we're getting, how much has been spent, who it's gone to, and to have a reporting tool so that if I access services from any of these providers and feel that I have been mistreated, because as Denise said, there is a lot of stigma and mistreatment, even for people seeking recovery. I want an easy way for those folks to be able to go in and report on that so that we are giving money to the good operators who are here for the betterment of the community so that we can start to heal together.
And one of the things, 1 minute, I really think it's important that we keep that money here in our state. There's too many of us here that have been out in our field, in our backyard for years, years. I think anytime we start bringing out-of-state resources in, New Mexico already has the resources. Again, this is not rocket science. We just need to come together. There's no sense of us getting this money and then giving it away to other states. We really need to take a look at that and look at what we have here already, and let's build on that.
You mean as far as treatment centers, organizations?
Absolutely, all of it, straight out, all of it. From ground zero all the way up.
And do you both plan to pressure the legislature in January?
Look, I don't know about pressure for me. To me, this isn't rocket science. It's just not. There is a solution. You can look at Kensington, you can look at Canada. I mean, the solution is there. It's just what lengths are we willing to go to implement it and fund it? When is enough going to be enough for New Mexico?
Well, I thank you both so much for your expertise and your commitment and your giving a damn.
Thank you for this opportunity, Dawn. I really
Thank you,
appreciate
Dawn.
you.
Yes.
Appreciate you so much.
Thank you both.
Tell all you love that you love them so, because even if you do, they might not know, and one day we'll all be gone. taste the wind, don't let it blow on by. Sing songs of love, let the music get you high. And when it's said and done, you'll know the sun will shine on. And when it's said and done, you'll know the sun will shine on. And when it's said and done, you'll know the sun will shine